Julian's asked me to come here today to explain the Compassionate City Charter. This is a charter that we're now promoting in several cities across the UK, and I'm part of the NHS Clinical Leadership Group in London, and we're trying to encourage the City of London Mayor's Office to embrace this charter. And so far it's looking pretty good. There is some reticence about it, but we're getting very close to an agreement that Morris will back this. So I thought I'd come and explain to you what is this charter and how it fits. So before we talk about the charter, we have to think about, I'd like to run you through a little bit anyway about the public health approach to end-of-life care. So if you're interested in embracing the public health approach to end-of-life care, we really have to understand the limits to service provision. Most of us are involved in service provision, but you have to understand that for the bulk of people's time, either dying, living with a life-threatening illness, living with a life-limiting illness, living with bereavement, service provision, professional contact is a small part of their life. It's also important to recognise that health is not simply about addressing illness and disease, it's also about the promotion of health and well-being. And we need to recognise and act on the fact that health is everybody's responsibility. You know, and you've known for some time now, at least for 30, 40 years, that to be healthy is not just visiting the doctor. Right? You know from the health promotion campaigns of the last 30, 40 years that you're supposed to look after your own health, you're supposed to exercise, you're supposed to eat well, you're supposed to do everything in your power to avoid accidents. You should wear your seatbelt, you should wear your condom, not necessarily in that order. You are supposed to read the nutritional information on the back of your cereal to avoid the 99% sugar one. Choose the healthy 80% one. You are supposed to eat more fibre, bricks and mortar. And all of this, of course, to prevent or harm reduce the problems that you will encounter. You're supposed to wear your seatbelt to avoid decapitation. So it's better to lose a spleen than it is to lose the head. The prognosis is better. You're supposed to avoid smoking and asbestos, reduce your alcohol intake to at least 5 shots of vodka a day. And the reason why we do all of these things is because we believe in the message of prevention and harm reduction and early intervention. We believe that if we take good care of ourselves, then when things go wrong, then there's service provision. Then there's the health services. There's the doctors and the nurses and the hospitals. All of this is true of ageing and dying and caring and loss. The social epidemiology of dying, death, caregiving and loss, they're all amenable to prevention, harm reduction and early intervention. We know about the anxiety and depression, we know about the social isolation, we know about the stigma, we know about suicides and sexual acting out, and the multiple problems that people have when they live with a life-limiting condition, a life-threatening condition, when they live with bereavement and grief. And all of these things occur 90% of the time outside episodes of professional care. So that's where we should be front-loading our efforts. So above and beneath and beyond and inside the so-called hospice movement, where people are dedicated, if you like, to looking after the dying and caregivers and the bereaved, we do have to remember that no matter what we do and how much we do in that business, it's always episodic. We come in and out, and at very best it's partial, and at best it's quite late. In bereavement care terms, it's never enough. I was recently in Canada and somebody was flashing up one of these models, you know, a block model, diagnosis, then further down the block, prognosis, then terminal, then death. Then there's a tapered little equilateral triangle called bereavement. I don't know where they get these people who design these models. Bereavement, if you actually have a look at that little triangle, it's half the length of the bit that says diagnosis, prognosis, death. We all do realise, I hope, how long bereavement and grief is for. It's for ever. And the 12-month memorial service, or the follow-up with the social worker or caseworker, doesn't even rate as token. Doesn't even rate as token. And usually that's the best, or not much better, what we can provide for the bereaved. So most of the time people spend dying, caring and grieving is in fact at home, work and play. And it's our responsibility to deal with this longer time at all times and in all these places. The Brent's approach to health and end-of-life care is in fact based on partnerships. Communities need to work with each other, but they also need to work with the health services as well. Health services have particular forms of knowledge which are useful to communities, and communities have particular forms of knowledge that are useful to the health services. What this means is that we can prevent, harm, reduce and act early to tackle our troubles. We can learn about the topics that affect us most in health, dying, death, caregiving and loss. And we can work with others collaboratively so we don't impose our strategies on others. And linked to that is understanding and working with diversity. Some people say, you know, there's some communities that don't talk about death and dying. There are no such communities. I'm here to tell you there are no such communities. Every community talks about death and dying. The question then becomes, what is the language that they use to talk about this? And who do they talk about these kinds of things with? And when you use a community development strategy, when you work within the communities, it's those communities that decide how best to communicate with each other about these matters. And that's the case whether we're talking about a school or a workplace, or a Muslim community or a Christian community. Doesn't matter. Therefore, our main methods are basically raising awareness and education. Most of us are familiar with the public health education. I've already talked about the cereals and the condoms and the asbestos and so forth, because you think about the death, dying, grieving information that needs to be known. So a lot of people out there think grieving only is just for a few days and a few weeks. There are people who need to know that this stuff is lifelong and it changes and transforms daily, monthly, yearly. There are people who understand that it's not just crying, it's arrhythmias, it's gastrointestinal disorders, it's sleeplessness, it's sleeping too much, it's fatigue, it's a lack of interest. It's a loss of direction. It's a loss of self. So not everyone knows that. Education, raising awareness, these things are important. They're the equivalent of health education. This is what the Americans call death education. Community development, of course, is that process that many of the palliative care services now in the UK who embrace the public health approach have begun, which is to use their volunteers differently, to create partnerships with high streets and schools and workplaces and trade unions and art galleries and museums and social media, to try to raise, if you like, the awareness, to bring up the kind of critical mass of understanding about death and dying. Community development is a partnership approach, always a partnership, a collaborative approach to working with communities about what they think they need to know about the thing that threatens them most. And then there's creating ecological changes in our communities. Now this is the one where I always spend a bit of time, because although community development is a difficult idea to enact, ecological changes are probably even more difficult for people to understand. So I'll just diverge for a sec, give you an anecdote. Before, I was Professor of Palliative Care in Australia for 10 years, but prior to that I was a Professor in Drug and Alcohol Studies. And I worked for a Quango, quasi-autonomous non-government organisation. They had basically sacked 400 civil servants in the drug and alcohol area and built a new empire called Turning Point Drug and Alcohol Centre, and re-employed about 150 of those people, as well as academics and clinicians. At the time I was head of the research division. I had about 30 staff, and there was a clinical division of about 70, and there was an education and training division of 30 or 40. We were in Melbourne, a city at that time about 3.5 million, and next to Melbourne was a little working class town, working class city of about 180,000 people. It was about 50 kilometres away. It's called Geelong. I don't know if anybody's ever been there. It's quite a nice place actually. Sort of. And it basically had 3 employers: the Ford Motor Car Company, Pioneer Concrete, and Shell Oil Refinery. These were the main employer groups. And every Friday and Saturday night, the workers, to relax, would descend upon the centre of the city and systematically begin to disassemble it. This had been an honourable tradition in Geelong for a very long time, and the police had tried everything, including the American zero tolerance thing. They would arrest everybody inside until their jails were overflowing. And the accident and emergency, the casualty departments, as we used to call them, would overflow on Friday and Saturday night. On Monday mornings, it was a ritual for the police cars to hose out their wagons from the bomber. And it was usual for the Chamber of Commerce to spend a considerable amount of money replacing windows and hosing down pavements from the blood. It's safe to say that if you wanted to make money in Geelong, you owned a window replacement company. They also had taken some advice from some health education people. I hasten to say conservative health education people, who thought that they could re-educate drunks. And so there was a pilot scheme that ran for something like 18 months where they not only arrested all the drunks, but forced them to go to re-education camps. Either way, that was as successful as a wet rag. So in the end, the Chamber of Commerce and the Department of Health and the Emergency Services came as a delegation to Turning Point Alcohol and Drug Centre, and they sat before me and they said, "Can you help us?" Now, I don't know how many of you work in drug and alcohol or have had a history of this, but this is not difficult. So I said, "Yes, we can help you. This is not rocket science, but we're not going to help you unless you do everything we say. So you drive back to Geelong, which is a trip of about an hour, and you think about that, and then one of you ring me and let me know whether you're going to be in this or not. Because if we implement our interventions, you can't do this half-hearted. You've got to go with it or not." So they drove back and they rang me and said, yeah, look, we agree, whatever you like. And so it became known as the Geelong Accord. It was a trial for 6 months. I sent my best researchers in, which were 7 or 8 people who were extremely observant. They weren't great methodologists, but if you came to work with new shoes one morning, they would say, "Oh, new shoes." Very observant people. I sent those people into Geelong every Friday and Saturday night for 6 weeks. They came back with their information. We sat down, we brainstormed, we developed 27 interventions. 27. So, I'll give you a few of them. We made sure that there was food on all the bars. We gave the police a healthcare role. They were not to arrest anybody on the streets unless their life was in danger. They had to pick them up and take them home. so to provide a kind of transport service. All the bars and clubs had music. We changed the music. They were allowed 2 head-banging pieces followed by a choir piece. So every Friday and Saturday night the music went 2 head-banging, 1 choir, 2 head-banging, 1 choir. We gave all the clubs and the venues, entertainment venues, a choice. They could either remove all the tables and chairs, or they could bolt them to the floor. In case you don't understand this, it's because drunks like to use furniture as headgear, not usually for themselves, right? So happily, for research purposes anyway, half of them went with bolting and half of them went with clearing the rooms. In 6 months, damage to public property and personal injury dropped by 50%. You can't talk to drunks and you can't educate drunks. Sure can change the environment so it's unfriendly to drunks. In Australia, most children grow up by the beachside and we go to little rock pools, and one of the practices we used to do in the 60s was put a little bit of kerosene in the rock pools, and you'd find that the fish would slow down. And if you put a bit of sugar in there, the fish would speed up. We're a cruel people in Australia. But it's another example of manipulating the environment to get the desired outcome. This is called an ecological management process. Businesses know it well. Anybody who's had 2 or 3 small children in tow in the supermarket and finally gets to the cashier and meets all those chocolate bars has been a victim of ecological management process. The question is this: if you had 27 interventions that you could implement to increase the health and well-being in death, dying, care and loss, and reduce the troublemakers in this game, what would those 27 interventions be? That's ecological change. It's also about creating new policies to guide new behaviours. You ring up most high schools, most workplaces. You ask most workplaces, how's your health and safety going? And they'll say, fine. Many will boast anti-bullying policies. This is the big thing now. 10 years ago, it was the anti-sexual harassment policies. They were great. Generally speaking, they don't build your workplaces out of asbestos anymore, and the smokers have to go outside with the badgers and squirrels. But ask them if they have a policy about what happens when one of your work colleagues drops dead. Most of them turn up cool. Ask them if they have a policy for when one of their work colleagues has a spouse with a serious cancer, or if they lose a spouse. What's their bereavement care policy? Most of them don't have it. You want to talk about work performance? Work efficiency? The fatuous use of social policies to improve the workplace? Think about the anxiety and the depression and the suicide and the sexual acting out and the loneliness that affects people when they grieve, and how that impacts on work performance, even staying at work. And of course, the other method that we need is working with our professionals in death, dying and grief, and not just palliative care. You know who sees the most bereaved people in any community? Aside from the funeral people and palliative care people. Vets. Vets. Not the ones that come back from the war. Veterinarians. Veterinarians. The bulk of the veterinary work is actually putting animals down. If you want to translate it in other terms, the bulk of the work of veterinarians is dealing with bereaved people. And bereavement over animals families as a form of disenfranchised grief. It looms large in the community. It's there, ever present, and it's continual. They're colleagues to work with, very experienced, as indeed are the intensive care people, as indeed are the aged care people, the hidden hospices in our society. All of these people have a critical mass of experience in death, dying and loss, and they are people who are terrific partners for providing leadership and facilitation of community discussions around death, dying and loss. So why do we need a charter if we can do all of these bits and pieces? We can do community development, we can do ecological change. Well, actually, we need a charter because we need to identify the key sectors of our community that need to be targeted for action. If you go to any hospice, palliative care service and you ask them, what does your compassionate community program look like? They're often very idiosyncratic. The community development program in Western will look very different from the community development program in Sandwell, will look very different from the community development program in Shropshire, will look very different from the community development program in Edinburgh. How can we be sure that all our sectors are systematically covered? Some will boast tremendous change in schools, and others will boast tremendous change in workplaces. Some will boast tremendous change in partnerships with faith groups, but the systematic changes are much more hard to obtain. The Charter is designed to facilitate a comprehensive approach, so we get literally a tick-box approach to the major sectors of a community, especially at a time when communities have contentious term anyway. And also to complement and foster community development approaches to work in all these areas. It doesn't matter how a school develops a guidance document on death, dying and loss. It doesn't matter. It matters that they start one. And once they start one, they'll do it collaboratively, hopefully. That is the point. They will do the community development within their community. But to begin with, someone must provide the leadership that says, hey, you need to look after people in these kinds of circumstances, because this is a normal part of the life course. And it's also to promote the clear message that end-of-life care should be something that comes out of our needs, something that we understand is of the people. There are lots of people, if you ask them, who would dearly love some kind of support, even a little bit of support during difficult times. Of course, there will always be people who will say, piss off. And that's fine. We can cope with that too. And there is the piss off dimension of this. But for a bulk of people, a little bit of help is very fine in their loss and in their caregiving and in their life with a life-threatening illness, a life-limiting illness. And it should be, once we realise what we understand we need, we should do it. In Britain in particular, we have this kind of view that if it isn't the family's responsibility, it's the government's responsibility. Actually, there's this huge slab in the middle, which is the community. It is in fact the workplace responsibility. It is the responsibility of your church or faith group. It is. It is the responsibility of the high street. Just like health and well-being is the responsibility of all of those places. You are not allowed to leave a gutted car in the middle of a footpath. That's a health and safety problem. You're not allowed to throw TVs from the 4th floor of a building. There are laws against that. There is a culture against that. Death, dying, loss and care is swept in and should be swept in those kinds of concerns. And then ultimately, this is for us. It's for no other reason. This is for us. And we've lived at a time for the last 3/4 of a century, in particularly as urban societies, where we've gradually de-skilled ourselves in the matter of death, dying and loss. And that's partly why there's been a massive rise in the desire for medical rescue, and not just by the Americans either. Here and everywhere else in the industrialised world, we look to our doctors to save us. But in fact, there is much we can do for ourselves. So here's the beginning of the charter. The charter is basically a two-page document, 2 sides of an A4 document. And it begins like this. Compassionate cities are communities that recognise that all the natural cycles of sickness and health and birth and death and love and loss occur every day within the orbits of its institutions and regular activities. A compassionate city is a community that recognises that care for one another in times of crisis and loss is not simply tasked solely for services. It belongs to us all. They're communities that publicly encourage, facilitate, support and celebrate care for one another during one's life's testing moments and experiences, especially those related to life-threatening, life-limiting illness, chronic disability, frail age and dementia, grief and bereavement, and the trials and burdens of long-term care. That includes a hell of a lot of us. And though local government does provide services for these people, it isn't just the people who are experiencing it now that's the issue. True public health doesn't have patients. Remember that. Public health is about citizenship. We don't wait till you go through a windscreen to tell you should wear a seatbelt. We tell people who are healthy to wear a seatbelt. We don't tell people after they've had a sexually transmissible disease they should wear a condom. We tell them before they get the sexually transmissible disease. So this is about what we should be telling each other now, what we should be doing for each other now. It isn't just, look, the bereaved are another vulnerable group, and the people with cancer are another vulnerable group, and the people with dementia are another vulnerable group. The hell with that. It's about us. It's before we get the dementia, before we get the disability, right? It's citizenship. It's about understanding the responsibilities of citizenship. That's what health and well-being is, and that includes death, dying, loss and care. So through the auspices of the Mayor's Office, a compassionate city, by public marketing and advertising, by using the city's networking influences, by digital collaboration and cooperation, develop 12 changes. Schools will have policies. Workplaces will have policies. Trade unions will have policies. Churches and temples will have at least one dedicated group for end-of-life care support. Most churches and temples do have groups who do social care and health care. Not all of them have end-of-life care, specific end-of-life care group. We would like to see them have an end-of-life care support group. Over half the city's hospices and nursing homes will have a community development program. Not just a volunteer program, unless that volunteer program is part of a community development program. Not just having volunteers that drive patients to outpatients or respite care, read books, take out the garbage, walk the dog, but volunteers that connect up with social media, who have contacts in the newspaper office and the television station, who know people in town hall, who've got a good contact in an art gallery and a museum, and are able to connect the hospice and palliative care service into a public education program. That could be done in partnership and that will be sustainable. The museums and art galleries would have exhibitions annually to help raise awareness and provide information about mortality. The city would host an annual peacetime memorial parade. We already have a Veterans Day, but that's just about war. Not that that's unimportant, but the bulk of people who die don't die in war. And the bulk of our grieving and our losses do not occur in war. And yet we have no public commemoration of that. It remains private and hidden away. There should also be an incentive scheme to celebrate and highlight the most creative organisation, event and individual. In Japan they already do this in dementia-friendly communities. Some of you may have heard of dementia-friendly communities. In Japan they have a national competition where villages and towns compete to show that they've got a way of running their town or village which is particularly friendly for people with dementia and those caring for them. It's a fantastic scheme. And it's an incentivisation scheme that works very well. There's also the need for local government and media to showcase the funding opportunities and events and festivals so as that there's a general umbrella idea of support and celebration of illness, loss and caring. And all the city services should be encouraged to distribute the material. In Australia, we had several local governments that had annual short story competitions. Do you know how much, does anybody know how much a trophy costs to buy? Not to win, to buy. Ever been to a trophy shop? No, obviously. How about a fun dog show? Trophy costs roughly around 50 quid for a nice one. And what you do is you just put it in a box or on someone's desk, and then the newspaper says, hey, there's going to be a short story competition this year. The best story about living with grief. And when we've done this in Australia, the place has been inundated with stories. And what happens is that all the people who write the stories get to rethink their loss. All the people then get to read about it, because the runners-up and the winners are published weekly. And a profile is given and a message sent to the community about how normal these kinds of experiences are. And next year it could be living with a life-limiting illness, or living with dementia, or living with long-term caring. All short stories. Highly popular, highly educational. Great for capacity building. Also, I think it's always important with any community development and ecological change that you're aware of the diversity. And there's a huge debate in the social science literature about what community is. People say, well, I don't really participate much in my local community. And that's a very old comment. I don't really have much to do. I live in this village, I don't know anybody. If you go to a dentist or you go to a vet, you have kids in school, you pay taxes, you go to your GPs, we'll get you. We'll find you. In all of those places. It doesn't have to be your community. You might go to a GP 3 villages away. But if that village is also a compassionate community, you won't be able to hide from our messages. In Australia, a few years ago, I went to the international airport, which is called Tullamarine in Melbourne, went to the toilet, closed the cubicle door, and what was there? Condom poster. In Australia, we lose about 40 to 50 people, or used to lose 40 to 50 people a year to AIDS. Quite a small amount of it. But you could not hide from our colleagues in HIV/AIDS health. Couldn't hide from them. The messages were everywhere. More strength to them. I could fill up the Melbourne cricket ground with 100,000 seats, and it would be standing room only, and there'd be a queue outside of grieving people, and I cannot find one poster telling me how to talk to a friend with loss. How is that? How is that possible? Does that make any sense in public health terms? And after a couple of years, those targets and goals are reviewed, and then one more sector should be added. Now, the Charter represents more than unusual public health commitment. You must have heard of healthy cities, and I think there's over 200 of them, formal healthy cities around the world now, overseen by the World Health Organization. And if you look at a Healthy Cities Charter, it reads like it was written by Walt Disney. The goals are lofty, extremely difficult. Some cities have conservative governments, some cities have liberal governments. Some of the healthy cities supervised by WHO have radical Marxist governments. But they all struggle to meet the goals, but they try. And many other cities who are not officially WHO healthy cities are healthy cities de facto because they have and strive to have policies that are not about strong health services, or not simply about strong health services, but having workplaces that are safe and that promote well-being. And they have schools that do exactly the same and make sure that when kids play in the playground, they don't break their necks. All we are saying with Compassionate Cities Charter is all of this should be swept under the same umbrella, that our health promotion responsibilities are to those living with a life-limiting illness, life-threatening illness, caregiving and living with loss, because they live with a great burden of trouble, and because their need for health and well-being is arguably more than most. At the moment, here's just one organisation that we're using with the CLG in London. This is what we're proposing for them at the moment. Boris will be at the top. He already has a mayoral team which takes care of health and social care services. We would work with the mayoral team. The mayoral team would work with a Compassionate Cities Advisory Board, composed of people who understand health promotion in relation to end-of-life care, community development in particular. There would be the end-of-life care leadership, clinical leadership group, and that would be representatives from the CLG, from the NHS in London, and then there would be a specific committee of people from the churches and from the Chamber of Commerce and so forth and so forth. And we would all work to advise. The community sector people would be the networkers, the movers and the shakers. The CC Advisory Board is to make sure that in the end, health promotion doesn't become health education, community development doesn't slide and become community work, and so forth and so forth. Conceptual and methodological slippage, if you like. And the end-of-life care clinical leadership group, of course, have a tremendous amount of experience in the area of death, dying and loss, and they provide content, authority and advice to the mayoral team about where their most suitable targets are. Now, who should use the Charter? Well, ideally the local government should take the leadership because the extensive influence and network over one geographical area, but it doesn't have to be. Political reticence, fear of failure or ridicule, denial of the widespread significance of end-of-life issues, or an obsession with services-only responses may mean that others need to provide community leadership. We've already had feedback from some local government people who have offered already some of these reasons for not participating, so this is not some thing that I've just brainstormed. It's surprising the number of people, even at local government level, who are afraid of the political implications of saying they're a compassionate community. You can't even get them to own something positive for them to worry about what the political cost will be for them. So the possible community players are churches and faith groups to do all of these kind of things, to infiltrate and to influence and to phone and to meet with workplaces and schools. Although the proviso should be, particularly in a multiracial, multicultural society, it ought to be, I would say, a coalition rather than just the Anglicans running this. Hospices and palliative care, public health services. Already there are a lot of hospices and palliative care services who are doing programs like this, very similar. And many of these people are in a good position to adopt and proselytise the Charter. Rotary, Lions, Apex, other service clubs are also very interesting organisations. They don't just raise money and do good for picnics and things like this. They're actually quite influential people. They're usually collections of local small businessmen. They have an enormous amount of networks, and they can actually adopt a charter as an organised way to do things beyond simple one-off events. Voluntary organisations and charities, Marie Curie, for example, Help the Hospices, those organisations can also spearhead, and some of them already have spearhead some very important health promotion programs within their authority. Chambers of Commerce and Business are also obvious areas of targets. But in all cases, I think the local government should be persuaded to participate or avoid a PR disaster if it works. These are some of the resources if you've not heard of the Charter before, or you want to read more about the public health approach. Thank you very much.